Hi. So I guess this was a nice break that my microphone did not work. So I guess everyone can hear me. Can you just tell me if you can hear me at the back? Thank you so much. First of all, I would like to thank you, BICC authority, to give me the opportunity to present our work. So this is our work that has been already published to Nature Communication last year in August. And today I'm taking the opportunity to introduce it to the Bangladeshi physicians so that let's see if we can help any of the Bangladeshi patients with their personalized peptide vaccine. So as moderator said, I'm Sanowar. I'm working as a business manager for the genetic diagnostic company called CGAT, Center for Genomics and Transcriptomics in Germany. And I'm here just only for the conference. So again, thank you so much for inviting me. So first of all, as you know, this glioblastoma is one of the major brain tumors that is associated with mainly elderly men who are more than 50 years old. What you can see here, there is a ratio of 1.6 to 1, so it's more common in men than female, and it's being elderly men are being affected with the disease. And also, even after the treatment, the overall survival rate of the patient is not so much. It's from 12 months to 21 months. And from different trial, it could go up to 7%, and from clinical trial, it's like around 10%. The genetic features of glioblastoma patients, they could be different types. They could be IDH wild type, they could be EGFR mutated, there could be atarax loss, there could be EGFR gene mutation. So, and there could be also chromosomal abnormalities, which then, that's the main reason for the uncontrolled cell growth of the cancer patients. So all these features contributed to the glioblastoma patient, and this was one of the reasons why we conducted this study. So if you can see the current therapeutic options, the standard of care therapy that is available here, that is surgery, then radiotherapy with temozolomide. It is for the newly diagnosed patient. So the best survival rate that you can find from this standard of care is from 15 months to 21 months. And then there are like FDA approved add-ons, that is TTF, and then tumor targeting fields for the newly diagnosed or recurrent patients, which add on around 4 to 5 months of to the median overall survival rate. And then you can also use bevacizumab, as you know, for the recurrent patients, which can improve the symptoms but not the survival. As well as you can see, there are multiple clinical trials. Unfortunately, the proven overall survival benefit was missing, so those clinical trials failed. So with us, what we have done here, we have analyzed this 173 patients in our clinic in Germany. So they flew to Germany, and out of there, as you can see here, out of 173, there were it was male-dominating study, and then we had categorized them based on the next generation sequencing profiling as well as immunohistochemistry. And then we have also profiled them based on the immunological data, clinical data. And this is a very good news that out of those 173 patients, as you can see here, 94 patients are still alive. That means our data was from 2015 to 2023, August. And so during that cutoff date, what we have seen, these 94 patients were still alive, which is a very good number for the glioblastoma patient, which is very aggressive type of cancer. For the patient characteristics, we had methylated, unmethylated, and also unknown. We have also primary and recurrent, as well as what we have seen immunological response. We have seen non-immunological responses, and there was also some patients with unknown immunological, unknown that we did not go for the immunomonitoring. What you can see here, so this is a very nice graph that gives you this red line is our data, and the black line is the data from the publications. So what you can see here, based on our treatment, the overall survival rate of the patient is relatively higher, is very significant compared to the published data from the different publications. What you can see here in this slide, that we have categorized them based on the immunological responses. And those immunological responses, as you can see here, the patient who respond with the patient who shows immunological responses definitely showed better survival rate compared to the patient who did not respond to the our vaccine. What you can see here, when we treated patients with our personalized peptide vaccine, and the patient who had the primary glioblastoma, that worked pretty well compared to the patients who had recurrence. What we have found from our study, that the personalized vaccine that we have been producing in our company in Germany, administering to the patient who are coming to Germany, that is immunogenic, that is very well tolerated, and it's feasible to produce and also apply within a reasonable time. So if you ask me what is the time duration, that is, let's say from the molecular profiling to the vaccination, it could take up to 6 months to 1 year, depending on the complexity of the patient. So these GBM patients, glioblastoma patient treated with our personalized vaccine, that shows really significant improvement in overall survival compared to the historical matched cohort that I have just shown in the previous slide. What you can also see here, that the prolonged survival rate, in my first slide, that what you have seen, the overall median survival rate of the glioblastoma patient, there was 12 months to 21 months, but with us, the overall survival rate after the first vaccination is around 53 months, which is really high compared to the available data. But of course, this method is approved or approved by Omics, but we need clinical trials, we need the approval of the FDA or EMA for the, let's say, to make it available for everyone. So what you can see here, I just wanted to connect the dots between the study that we have done and the work that we are doing in the lab, so that you can correlate the work that we are doing. So I will just make it pretty fast. So we were doing the profiling of the patient based on the tumor as well as the normal tissue to give you the real data. There is, because when you are not doing the profiling of tumor and tumor tissue, it will not comparison with the normal tissue, the data could be false positive up to 27%. And then we are doing the assessment of the tumor tissue by our pathologist that is also based in Germany. And then we are doing the sequencing. It's a comprehensive profiling including different parameters on the DNA and RNA level. And then we are doing the bioinformatics and identification and detection of the therapy relevant SNVs, indels, TMB, HRD, MSI, and all the other biomarkers that is relevant for the patient. And then finally, we are doing the reporting. And then based on that report, the patient has been treated in our own clinic in Germany. And so I just wanted to show you a journey of a non-small cell lung cancer patient. What you can see here, so normally when you have a patient, you go for the EGFR PCR based, and then you go for the different other tests when this comes out negative, and then you go for the another test, and then you go for the lung panel, and this process could take up to 2 months, 2 to 3 months, depending on the complexity of the test. And then you find the partial identification of the treatment options, which is very, in this case, that could lead to a high cost because of this multiple test. And then the partial profiling may risk the resistant genes, and there is no germline variance that is detected. And then, but when you are doing the comprehensive profiling, you go for the comprehensive profiling on the first day, and on the 21st day, you get the report and you can treat the patient. You can save time and money because there is no ineffective treatment, or everything is targeted treatment. And then you are getting the information on the germline variants, you are getting information on the pharmacogenetics, you are getting information on the tissue and the blood as well. So with this, what I can also tell you, like there are like multiple different services that can give you from our company. So it's a total complete genetic diagnostic solution for your patient, depending on what you need, it based on the solid tumors. And when all these different approaches fails, still you cannot solve the case, then you can also maybe go for this personalized vaccine. And then this is the sample report that you can see and all the drug recommendation that is available from the report. And there are like different type of situation where you can consider the genetic testing. I guess my time is over, so I will not go further in detail, but you can always contact me. I can come back to you personally and we can discuss. And the good thing is we are already receiving samples from Bangladesh. There are certain physicians who are believing in us. They are already sending samples. They are receiving reports from us, and they are already treating the patient based on our report, which is very good. And we are getting the sample from Bangladesh within 3 to 5 days, depending on the logistics and everything. And in German, we call thank you in vielen Dank. Thank you so much for your time. And thank you so much, BICC, for giving me the opportunity. Thank you.